If we screened for metabolic dysfunction with the same vigor that we do breast imaging, we would have a very different health status.
Welcome to the Dutch podcast, where we dive deep into the science of hormones, wellness, and personalized healthcare. I'm Dr. Jaclyn Smeaton, Chief Medical Officer at Dutch. Join us every Tuesday as we bring you expert insights, cutting-edge research, and practical tips to help you take control of your health from the inside out. Whether you're a healthcare professional or simply looking to optimize your own well-being, we've got you covered. The contents of this podcast are for educational and informational purposes only. This information is not to be interpreted or mistaken for medical advice. Consult your healthcare provider for medical advice, diagnosis, and treatment. Hi there, welcome to this week's episode of the Dutch podcast. I'm really excited that you're here with me today because we're going to dive really deep into menopausal hormone therapy and breast cancer, but also talk about the fact that breast health is just health. And we're going to talk about a lot of the underlying factors that might surprise you that influence your risk of breast cancer and your survival of breast cancer. My guest today is Dr. Jenn Simmons. Now, she used to be a breast cancer surgeon, and she stepped away from that and really sparked a revolution. She's the founder of Perfection Imaging, but really she's committed her career to disrupting the fear, the confusion, and the medical dogma that's controlled women's breast health for literally generations. On today's pod, we are going to talk about how we got to the point where we have said women with breast cancer or after breast cancer should never get hormone therapy. We're then going to talk about how things have changed. What does the data actually say? And believe it or not, just recently in JCO, the Journal for Clinical Oncology, they just put out a statement in their publication that we should be really talking about hormone therapy for women with breast cancer and not just having a blanket prohibition. This really supports the work that Dr. Simmons has been doing for literally decades. Now, Dr. Simmons is a really compelling speaker, and we're going to dive right into the research. So let's go ahead and get started. Dr. Simmons, I'm so glad to have you back on the podcast. When we had you live at A4M, it was so much fun, and I remember thinking, gosh, we're just getting into the story and we're out of time and we need to have you back on. And so here we are.
Yeah,
Welcome.
I'm so happy to be here.
Now, I want to just remind listeners and kind of get people caught up to what we talked about. And we'll link to the previous recording. I really recommend you guys listen to that if this is a topic that's interesting to you. But I want to just remind listeners and have you start out by talking about kind of the core arguments around estrogen, progestins, and breast cancer risk, because you really blew my mind right open and really challenged a lot of the assumptions that I'd been taught by kind of the standard approaches to menopausal care, like Menopause Society or NAMS at that time. And now things are really changing, even since we talked last December. So let's start by just talking about the core arguments around these. What do people believe, and what do you think that's different?
Well, the narrative that has been in place since the early 2000s were there for very intentional reasons. And when we went into the Women's Health Initiative study, the primary investigators went into that study with great intention. It was no accident that their findings were their findings. Mm-hmm. Because if you can somehow create a belief that estrogen causes breast cancer, then you create a situation where women would then actively choose to not have estrogen. And estrogen is the hormone of life. Mm. So without estrogen, women start to lose their mind. They can't sleep. They're anxious. They're depressed. Their joints ache, their bones ache, they become osteoporotic, they gain weight, they have mood disturbance, they lose their libido, they lose their vaginal health, their bladder health. I mean, really all of it, right? And in that place goes a lot of pharmaceutical medications, right? In that place goes antidepressants and anxiolytics and sleep medications and bisphosphonates and weight loss drugs and things for your heart and things for your cholesterol and things for pain and on and on and on, right? So you can easily see a scenario where if a woman is not on hormone replacement, she could easily be on 3, 4, 5, 6, 7, 8, 9 pharmaceuticals. And this isn't a one and done kind of thing. As these pharmaceuticals come on board, they're forever in the minds of the manufacturers, right? So they're creating this incredible customer base by having women believe that estrogen is the problem. And it really, really worked. It really, really worked. When they came out with their position statement that hormone replacement caused breast cancer, that there was an increased incidence of breast cancer in the women who took hormone replacement, and they made that blanket statement, it was kind of like the science is settled, but no one asked for the science. And it wasn't there. And the people that were part of that original Women's Health Initiative study that said, wait a minute, this isn't exactly correct. What we're putting out there isn't exactly correct. They were just drowned out by the voices that were so willing to believe it and wanted, very much wanted to create this narrative. Now, fast forward, that opinion has been completely retracted. There was a position paper that was printed in 2017 that I think like you, me, and maybe 5 other people read. But all of those findings were completely retracted. And it's only now that people are looking at the real data that came out of that study. And the real data is that in the patients that were given estrogen alone, now they weren't given bioidentical estrogens, they were given conjugated equine estrogen, which, you know, I can still argue it was not a good thing to give women. But even in that, we saw a 23% reduction in breast cancer. Like, this should have every single practitioner up in arms. And even if they are, right? Even if we are setting the stage to say, okay, it's not the estrogen. And when we actually look at the data, and we look at the data across the board for both pre-breast cancer studies and post-breast cancer studies with hormone replacement, the only signal that we're seeing that is tied to an increase, either primary breast cancer or recurrence, are for progestin containing formulations. Not progesterone, progestin. And the biggest problem that we have a lot, but the biggest problem that we have is that most providers don't know the difference.
Yeah. Well, tell us about the difference.
Yeah. So when you look at the chemical composition, a progestin looks very different than progesterone. And progesterone will attach to the progesterone receptor and do what progesterone does, right? So if estrogen is our on button, progesterone is our off button. It's our calm button. It allows us to sleep and think rationally and be calm and not overreact. I mean, that is amongst other things that progesterone does. It stops bleeding. It is actually the balancing hormone to estrogen. Progestins actually have estrogen-like receptor activity. And so it was a double whammy of stimulation for women who were on this drug. So what no one realized, and providers included, was that when they were giving these synthetic combined formulations, they were actually creating something that was very unphysiologic. And they have the cancer to show for it. So the reason why providers don't know the difference between progesterone and progestins is because they have been used synonymously both in practice and in the literature.
There's so
And
much confusion around that.
there's so much confusion, and you really have to be a discerning researcher to know the difference and to recognize the difference. And most providers are not.
Yeah. So just to summarize it, like we have this category of compounds that are called progestogens. That's our umbrella term for you listeners. And then under that, there is progestins, which are always synthetic, but still bind to the progesterone receptor. And then there's progesterone, which is what our body makes. There's bioidentical progesterone available. Progestins, I always say synthetic progestins. Whenever I say progestins, I always say synthetic progestins to try to help people avoid that confusion.
Yeah.
The other thing with progesterone that's interesting, and Mark, I'd love you to kind of talk about this a little bit. And again, this is just some background information to set the stage. Progestins, synthetic progestins, do not break down into progesterone metabolites, which also have biological activity. And I think that's another thing that's commonly misunderstood. You don't get the benefits of like allopregnanolone or the brain calming benefits. You can only get that from bioidentical progesterone. Can you talk a bit about that piece, Mark? And then I want to shift back to talk about breast cancer.
Yeah. And just to double down on what you said, it's pretty frustrating when you read. I have seen somewhere you read an abstract that uses the word progesterone, even in an academic setting, and then as you peel down into the paper, then you see that they're actually not talking about progesterone, and so when people are drawing conclusions, even sometimes if you just read the abstract, you can actually be misled, even if you're well intentioned. But yeah, the thing with progestins too is it's not a thing. Like when you get to birth control estrogen, you're pretty much always talking about ethinyl estradiol, which you can study. But then with progestins, there are so many of them that, of course, they have different impacts than progesterone, but then they have metabolites themselves, and which have not been studied extensively at all. And progesterone, of course, has that pathway that it goes down that creates allopregnanolone and the compounds around it. Like we measure allopregnanolone or alpha pregnanediol, and it has some of those similar sedating effects. But that whole family of alpha metabolites has that impact, and who knows which progestins have some of that or some distorted version of that, because some of them do get metabolized the same way, but then they're still chemically different at different parts of the molecule. And so, assuming that you're going to get those same effects, because you do get progesterone effects, but then it also acts as a prohormone, and you're getting those metabolite effects. All of which we shouldn't assume.
Some of those metabolites will have ER alpha activity as well, which is why we get into trouble with those compounds because of their effect. It's not their effect on the progesterone receptor. Those are the wanted effects. But the unwanted effects are their effect on the ER alpha receptor. So when we look at our estrogen receptor activity, we have to talk about the specific receptors. And there are stimulatory receptors and non-stimulatory receptors, and they work in balance with one another. But when you have these synthetic progestins that have some progesterone activity, but some estrogen activity, that estrogen activity that they have is the ER alpha activity. And so we get into a whole system where we're out of balance because of the decision to introduce a compound that is acting across different receptors.
I'm so glad we're covering this. So sorry, I didn't mean to interrupt you. I thought you were, but that's so important. I'm so glad we're covering this because I think the lack of understanding or the amount of confusion that's erupted in this industry and still exists right now with the perceived interchangeability, and I'll even add OCPs in the mix because you see OCPs given to women in perimenopause, which again, you have this synthetic ethinyl estradiol combined with some kind of synthetic progestin, and most OB-GYNs believe that that's equivalent to like a bioidentical menopausal hormone therapy regimen. There's not a clarity around different impacts of these things, but they truly are different drugs. Every progestin natural progesterone, and then ethinyl estradiol, and then you have your different forms of natural estrogens. We need to be thinking about these and compartmentalizing them as unique compounds in the body, not
Without
conglomerating them
question.
all together.
Without question. But this is the crux of it, and this is the problem that we have and that we're going to continue to have because of the results of the Women's Health Initiative and essentially all learning and knowledge about hormones was suspended, frozen in time. We have 2 decades of providers who are untrained or undertrained, unknowledgeable, don't know the difference between a progestogen and progesterone, don't even know what the native compound is supposed to do or where it's supposed to do it, right? Like there's still this perception that estrogen is only for procreation and sexuality, and there's no reason to replace it afterwards. I mean, there's just a complete lack of understanding of what the purpose of these compounds are. And so even if we decided today, that hormones are safe, who's going to provide them? Because what we have out there is a bunch of providers who don't know anything beyond birth control pills and don't even know or understand the dangers of birth control pills. I mean, we have a Denmark study of 1.8 million women that shows a linear relationship between birth control pills and the development of breast cancer. All comers, all ages, not just birth control pills, any hormonal birth control, because any hormonal birth control is going to be progestogen containing, synthetic progestogen containing.
It's interesting that you mentioned some of the progesterone, progestin, those metabolites hitting the estrogen receptor. I'm curious, when they teased out the data, then it would have been a shocking finding to say that the progestin is causing cancer and the estrogen isn't. If the estrogen went back to a risk, or whatever you call those stats, a risk ratio of 0, that would have been really interesting. So were you surprised that the estrogen alone arm actually had a reduced risk of breast cancer? And given the role of estrogen receptor potentially in breast cancer, can you just speak to, like, why would that be? Like, that surprised me. Like, I would have been happy with net neutral, right?
Right.
But the fact that it reduced the risk, my mind still can't quite understand the impact there or why that is. Could you speak to that?
Yeah, I think it's because of the ER beta activity. So while we measure ER alpha, because we know that is the stimulatory estrogen receptor, the ER alpha receptor, we are not measuring ER beta. But there's really no other explanation for me other than conjugated equine estrogen has a considerable amount of ER beta activity. And so by virtue of that, it is lowering proliferation. And we know that, the more proliferation you have, the more likely you are to make a copy error, a copy mistake. So that is the cell 0, right? That's the original cancer cell. That if that goes unchecked, then 2 daughter cells and 2 daughter cells and 2 daughter cells, and before you know it, you have a mass, right? If you are instead not stimulating the alpha receptor, but stimulating the beta receptor, that is going to be anti-proliferative. So that's going to turn off growth and decrease the risk of breast cancer.
There was actually a really interesting study that just came out. I will send it to you. It was published in March in Nature Aging. You may have seen it. It was basically looking at aging of the human breast tissue, and it went beyond like mammographic density and looked more at what's happening at a tissue level. And it was really interesting because they identified a couple of key things. One was that what we really saw was there were massive changes, particularly in that, what I read to be that like perimenopause, that kind of 12 months before the last menstrual period, where the withdrawal of estrogen causes massive changes to the breast tissue at a tissue level, where there's a lot of immunologic changes, where the ability to kind of surveil for these aberrant cells really declines. It's almost like it becomes lazy without the estrogen there. And it was really thoughtfully looked at because we look at breast cancer in younger women, which is growing right now. Rates are growing. And breast cancer in older women, and the types of tumors that happen are quite different. More aggressive in younger women, and more likely to be ER negative, right, compared to older women. This is your expertise, not mine. But I just found that really interesting because, again, it speaks to that importance of that continuous supply of estradiol too. And it got me thinking about all the work with WHI. And the other thing with WHI is, remember, the average age of women in the study were in their early 60s. So these women had a withdrawal from estrogen for like sometimes upwards of a decade before it was reintroduced. And you think about all the tissue changes. I always tell Mark the issue is the tissue, right? That's like my new favorite slogan. It's the changes in the cells that impact the way hormones are used. And I really liked that. I'll put the link to it in the show notes for those of you who are interested. It's open access. But really interesting to be looking at how that withdrawal from hormones in menopause changes the breast cancer risk when you reintroduce hormones later.
Absolutely. And the thing that we don't talk about enough, because everyone has been trained to think that breast cancer is somehow a disease of hormone excess, it's not. It's a disease of hormone deficiency.
Okay,
right?
Let's talk more about that.
Yeah, absolutely. First of all, this whole concept of estrogen dominance, we're not suddenly making more estrogen. Yes, there are xenoestrogens, and that is contributing to disease states for sure. But estrogen dominance isn't really about estrogen dominance. Estrogen dominance is about progesterone deficiency. And the less healthy we are, the less progesterone we have. And the whole reason, I believe, that we are seeing cancer younger and younger and younger is because in a normal lifespan, a normal hormonal lifespan, we expect to see the loss of progesterone approximately 10 years before we lose our estrogen. And all we're seeing now is an accelerated timeline because the less healthy we are, the less progesterone we're going to produce. And so we are looking at the effects of a loss of progesterone. Because progesterone is protective. It is anti-proliferative. So if you don't have that protection around and you're losing your safeguard, you're going to have more cancer without question and at a younger age.
Can we put this in context also? Like, I'd love for you to share what we know about a woman's reproductive lifespan in breast cancer. So things like the age of menarche or the number of pregnancies, because I think it's helpful to put it in perspective with our natural production of exposure of hormones. For example, in pregnancy, your hormones are very, very high progesterone, high estrogen for this period of 9 months. And we know that, with women have pregnancies, it can change breast cancer risk later on in life. What do we know? Like, what are some of the takeaways?
It actually decreases it.
Exactly. That's what I'm saying. So the more pregnancies, the more protection you have. That's a situation with very high hormones.
Yes.
So can you share a little bit about what the takeaways are about just natural?
Well, so I think that when we were saying that women who started their cycles earlier, that is a breast cancer risk, I honestly think that was tied into that whole mentality of hormones are bad.
Okay.
Right. And so if you have hormones at a young age, it's bad and it must be tied to breast cancer. If you think about it, a woman who is menstruating longer, right? That is probably a significant mark of health and ability to menstruate for longer. So I would love to really look at the data with the critical eye that I have now, because as I wrote a breast cancer risk analysis program this last week, and I kind of put into Claude AI, am I missing anything? Like I named all of the things that I thought were important, and am I missing anything? And it said, early menarche and late menopause. And I came back to Claude and said, let's really talk about this. Is that true? Because I think that is another thing that we were sold in that hormones are bad, and so the longer you have high hormone levels, the higher your risk is of developing cancer. But I don't know that that data really exists. I don't know that that's true. And when you look at the times in a woman's life where she has the most hormones, teenagers, pregnancy, you have 10 times the amount of circulating estrogen and progesterone. These are not times that are associated with high incidence of breast cancer. And breast cancer is a disease of women who are hormone deficient, because hormones are innately protective.
This story gets complicated when we start to talk about what happens to estrogen when it's in the body. Mark, can you talk a little bit about what we know also around breast cancer risk and estrogen metabolism? And I want to also layer in the fact that these studies are mixed, but when we look at the good data, which would be LCMS data, they are not mixed. And I'd love you to touch upon that.
Yeah, it's a confusing topic that I have to go back and like refresh yourself all the time, because there is a lot of old data that's analytically not as good. And then, when you look at the estrogen metabolism, you've got those three pathways of the 2-hydroxy, the 4-hydroxy, and then the 16-hydroxy. The 2-hydroxy definitely seems to have some protective properties when it comes to breast cancer, or that's my understanding. And then when you look at the 4-hydroxy, it's got I was actually just looking at one of the kind of older papers that has this beautiful pathway that breaks down, that pathway from estrogen to 4-hydroxy, and then it can get methylated, or it can move on towards that active quinone where it can, attach to the purine, the DNA, and make those DNA adducts where you're actually seeing sort of a physical DNA damage from the estrogen metabolites, that 4-hydroxy that specifically has that, the nature of that. And so the relationship between the 2 and the 4 and the importance of methylation, we talk about that a lot. I'll be honest with you, I'm still a little bit confused, and maybe Dr. Simmons, you can add your perspective on the role of the 16-hydroxy. We know that it has a unique relationship in that it can create covalent bonds with the estrogen receptor, and some of the older studies show that there may be some breast cancer risk associated with the 16 relative to the 2, and look at the ratio there. But that is one where the studies are mixed depending on which one you're looking at, and I wouldn't state that it's real clear on that one, but the mechanism of 4-hydroxy and DNA damage and the cancer rates you see, particularly people who have the genetic defects of making the 4, not methylating, and then not detoxing. When you stack those 3 up, you definitely get the higher breast cancer risk. So how your body deals with estrogen in terms of phase 1 and phase 2 metabolism definitely plays a role, but it is complex. I'd be curious to know just kind of what your perspective has been on how the literature's kind of evolved with that over the years.
Yeah, I'm going to agree with you in that I think it's very easy for us to picture and understand how the 4-hydroxy pathway can directly damage DNA and set the stage for cancer, right? And that seems very clear to all of us. And then the 16-hydroxy pathway is not so clear. And I also don't know that in vivo studies are entirely possible with isolating these pathways, because all of this is really in the face of, is this person inflamed and metabolically unsound, or is this person metabolically sound? Because I think what we're seeing are the downstream effects of metabolic dysfunction and inflammation. And when you correct them, do you at the same time correct some of this metabolic findings, right, in terms of estrogen metabolism? So I don't know that we can tease them apart or blame something like 16-hydroxy when that is just there as a result of metabolic dysfunction. And I have long said that if we screened for metabolic dysfunction with the same vigor that we do breast imaging, we would have a very different health status, right? If we instead screened for metabolic dysfunction and corrected that, we would see very different things, including what the downstream metabolites of our estrogen metabolism are.
Could you define metabolic dysfunction there? Jaclyn, just before, in terms of what you specifically would measure to separate people who do that well
we're
and
gonna
poorly?
let's talk more about that for sure.
Yeah. So instead of everyone going and getting the kind of precursory labs that they get every year at their doctor, like maybe they get a CBC and maybe they get some electrolytes and a what they call a complete metabolic panel, which is anything but, and your basic lipid panel. What we should really be looking at, because by the time your, let's say, your fasting glucose is elevated, you're already far down that pathway, right? Your body will work really, really hard to keep that in an acceptable range, because being hyperglycemic is so very toxic to your cells, right? So there's going to be a lot of compensation before that happens. So instead of measuring fasting glucose, why aren't we measuring fasting insulin?
You're so right. We need those early indicators.
Yeah, early indicators. And why are we allowing people to walk around with hemoglobin A1Cs in the mid 5s for years without saying, what's going on here? Why is their average glucose well over 100, enough to make your A1C in the mid 5s? So we are not looking for metabolic dysfunction. And at Perfection Imaging, this is part of your basic screen. When you come in to screen for breast cancer, we're not just imaging your breast, because that has nothing to do with prevention. If we find something on your imaging, the cat's out of the bag or the horse is out of the barn, or I forget which one is the one that you say, or maybe both, right?
Yeah.
Like it has already happened. And what I'm looking to do is to actually prevent disease. So we're looking at your fasting insulin, yes. We're also looking at your triglycerides, your HDL, and measuring a triglyceride to HDL ratio. We're looking at some body composition metrics. We're looking for a high sensitivity C-reactive protein. I'm also incidentally looking at vitamin D, because vitamin D levels are highly predictive of who does and who does not develop disease and dysfunction. We're looking at a waist to hip ratio, waist circumference. We're looking for the things that tell us, are you metabolically sound or are you not metabolically sound? Because if you're not metabolically sound, this is just setting the stage for dysfunction, and it's going to lead to dysfunction across the board. It's going to lead to hormonal dysfunction, and then it's going to lead to some end point that we readily recognize but rarely talk about where it came from or why it's there, right? So diabetes, hypertension, coronary artery disease, peripheral vascular disease, overweight, obesity, cancer, autoimmune disease, any of these diseases, they're starting off as metabolic dysfunction, but we're just not looking for it. We're not measuring it. And I think we're not doing it because we don't know, as medical providers, most people don't know what to do with that information. They don't know how to optimize people's health, so they're not looking for health optimization. They only know what to do when you've failed, and their what to do is suppress the symptom.
It's such an important conversation, and I'm so grateful for you raising it, because I think hormones never work in a vacuum. There's the hormone in the bloodstream, but it's the cell's response to it. And I think people get this when it comes to glucose and insulin. I like to use that as an example, where now everyone knows the term insulin resistance. And what that means at a 50,000-foot view is that the cell is changing the way it responds to hormones first. That's the first stage of disease development towards diabetes type 2. then what you have is you eventually have hormonal changes that follow that. So I think that it's like the cart before the horse. And when we are only looking for the hormonal changes, you are missing the opportunity for early intervention. And I love that you phrase that, because in America, when we talk about preventive medicine, what most people mean is preventive screening or early detection screening, pap smears, mammograms, colonoscopies. What they are not doing is what you are doing, which is looking at the foundational layers that drive, in your case, breast cancer development. You know, we know that chronic inflammation, oxidative burden, and even sleep disruptions have been identified by the World Health Organization as a human carcinogen, a possible human carcinogen. You are upstream from the detection to true prevention. And I want you to talk some more about that, because one, I think for other people, especially like, you know, other breast surgeons maybe who follow you, breast oncologists, if you've never heard you, Dr. Simmons, speak before, this could be a very new concept. But can you talk a little bit about, like, before a woman gets on hormones, what would that workup look like? I mean, you've described some of those cardiovascular pieces.
Yeah, absolutely. Well, what we all need to understand is there is no magic pill or potion or anything, right? Hormones can be extremely helpful and life enriching, but they are not the be all end all, in that they are the bow on top of the box. And the box is filled with all of those foundational things that we all need, and we need them first. Now, can you always optimize people's metabolic health before putting them on hormones? No, because part of our metabolic health is tied to having hormones. But at the same time, I'm not giving hormones to someone who hasn't tried to optimize their sleep, who hasn't tried to optimize their diet, who isn't moving and is sedentary, who isn't lifting weights, who is still using alcohol or drugs as their escape or as their self-care, right? As my kids would say, Mom, that's not it, right? It's not how it works. And if you want hormone replacement to work, and if you want hormone replacement to be safe and to be part of your longevity plan, then you have to lay it on top of a foundation that sets up for health and longevity. And that is, you know, eating in a way that's nourishing, having a fasting practice, make sure that you're moving your body and not just being an exercising couch potato, but someone who is moving their body throughout the day, because we are nomadic people. We're meant to move our body or we lose our body. And we have to lift heavy things, right? The water didn't come to us. We had to go get the water, right? So we're meant and built to lift heavy things. And that's how our bones become strong. So you can't have any expectation of strong bones if you're not demanding your bones be strong, right? Bone follows muscle. So you got to work those muscles so that you build strong bones. And you have to prioritize sleep. Sleep is where the healing happens. And if you're not sleeping, you're not healing, which is why it is a known carcinogen to not sleep. Right? Because if you can't do the tissue repair, then you're just going to have a lot of broken cells, a lot of rogue cells. And we unquestionably live in a toxic world, and you're never going to be able to escape all the toxins, but you got to try. You got to do your part. And the easy things like not drinking out of plastic and not cooking in plastic and not storing in plastic, and like the easy things, you just have to do it. You have to do it. You have to eliminate as much as you can. And having detoxification practices. And some of that, you know, I'm not saying that everyone needs to sit in their sauna and meditate all day long, but I am saying that you got to take the trash out. Right? And sometimes that means you got to break off that relationship or get out of that situation. Like whatever the garbage is that's surrounding you, you got to figure out how to get rid of it. You have to. And we all have to live life with purpose, because if you're not doing that, if you're not motivated by whatever you're out there doing, then that is not a path to longevity. And so when I'm working with someone, we're tackling all of these things first before I even get no one has prescription pads out anymore, but before I ever get my virtual prescription pad out, we're working on all of these foundations. Because again, hormones are wonderful. They're life-changing, but they are not the thing. They are the bow on top of the box.
We'll be right back with more. If you're already running Dutch tests in your practice or thinking about it, there's never been a better time to become an official Dutch provider. Why? Because we go beyond lab testing. Our provider community gets exclusive access to clinical education, in-depth report interpretation, training, monthly case reviews, and one-on-one clinical support. Whether you're just getting started or looking to sharpen your functional hormone expertise, we give you the tools to grow. Join thousands of providers already making a difference. Visit DutchTest.com today. Welcome back to the Dutch Podcast.
Yeah, I would love to roll off what you were talking about as it relates to sleep. Well, there's an interesting study that looks at breast cancer patients and some of the markers that we look at. Well, a combination of studies. So we look at the melatonin metabolite in the waking sample, which is essentially a pool of what you've made over the night. And you can see substantially lower in people who get breast cancer. And then if you switch your focus to the marker that happens to be right next to that on our test, which is the oxidative stress marker, and you look at breast cancer patients, it's substantially higher in those people. And if you look at studies where they've looked at each other, they negatively correlate with each other. So this all makes like a story that makes sense. And then they also tie in terms of correlation with cortisol. And when you look at cortisol and breast cancer survivors, people that have those flat cortisol patterns don't do as well in terms of survival. So I've got this sort of triangle of data of oxidative stress, melatonin, and just kind of crappy cortisol results, and they all interrelate. But most of those studies are on people who already have breast cancer, right? That's an easier way to ask that question. So I was wondering if you could take that story of sleep, which relates to cortisol and melatonin, and both of them relate to our oxidative stress marker. So if you move that story back to a prevention story, how do those relate to each other, of melatonin being, an antioxidant, but related to cortisol and oxidative? So could you sort of tie those together in terms of not once you have breast cancer, but in terms of risk?
Yeah. Well, if you think about melatonin, instead of, most people think that melatonin is what makes you sleep. That's not it. Melatonin is what you make when you sleep. And if you think of melatonin as your repair hormone, the less melatonin you make, the less repair you do. So breast cancer is this intersection between cellular damage, DNA damage, and an immune system that is supposed to be surveilling for these damaged cells and kind of destroy them or take them out of circulation in their infancy before they can reach mass proportion and become a tumor, right? So if you think of melatonin as something that is allowing your body to make the repairs, not make so many mistakes, or at least do the repairs once you've made the mistakes. If you don't have that repair serum, you can see how this can easily lead to an increased incidence of cancer. But it's not only just cancer that's associated with these low or depleted melatonin levels. It is being overweight, it's obesity, it's heart disease, it's any chronic disease, autoimmune disease, any inflammatory condition is going to be more prevalent in the population of people who both have low melatonin and are short sleepers, insomniacs. And what's even more interesting is that you can sleep the right amount of time, but if you're sleeping at the wrong time, you're also going to be melatonin deficient. So if you are a night shift worker and you are dutifully sleeping during the day, it won't work. You still have increased risk of chronic diseases. And if you are sleeping, but it's not dark in the room, you're also going to make less melatonin and have more chronic disease. So my question is it purely that you're not asleep so you're not making enough melatonin, or is there something else that's going on that is not allowing you to make enough melatonin in order to do the repairs that you need to do? And I think that that's the unanswered question, at least for me. Is it the lack of sleep leading to a lack of melatonin, or is there something else that's going on? That are you over consuming? Are you not able to make enough? I'm not sure that I understand the total picture, but I do know that low melatonin levels and low sleep levels are absolutely, without question, directly correlated with chronic disease states, cancer being kind of the end of that spectrum.
Yeah, when you talk about repair and then that oxidative stress marker also going up when your melatonin is low, and in people who get various types of cancer, that like connects some of those dots, I think.
So that
a little bit.
oxidative stress marker is just a reflection of the repair that didn't happen,
Right.
Yeah.
right? Because it's a direct result of DNA damage.
Now, Mark, a lot of people order the DUTCH test. A lot of clinicians order it because they want to take a look at estrogen metabolism ratios when they have breast cancer in mind. But given everything we've talked about today, that's obviously an incomplete use of the markers on DUTCH. Now, before I ask you this question, DUTCH test is not a diagnostic test. It does not diagnose risk of cancer. There's no data correlated to breast cancer risk. It's not a screening tool. So I want to get that out of your head. We're not making any kind of claims that the DUTCH test can diagnose risk of cancer or active cancer or anything like that. However, the concepts that we've talked about today, metabolic health, oxidative stress, inflammation, estrogen metabolism, let's put estrogen metabolism aside because we've talked about that. What other markers are important for clinicians to look at on the DUTCH test for this group of patients when we're thinking about prevention and we're thinking about how to assess some of those underlying functional contributors?
Yeah, well, the odds ratio for just that melatonin, looking at the lowest quartile versus the highest quartile, that's 0.6. So that's a pretty significant, change in terms of risk of those that don't make very much melatonin and those that have nice, healthy levels. So that's, that trifecta of cortisol dysfunction, oxidative stress marker high, and melatonin low the data on that's pretty strong in terms of the risk between the sort of haves and have-nots in terms of those levels. And then, of course, estrogen. And we talked about progesterone as well. I think those would probably be, on the top of the list for me in terms of not just having a theoretical, conceptual relationship, but also that there's, solid data that shows that there's a difference. I'd be curious for you, Dr. Simmons, when it talks about, are you making enough progesterone? Is your estrogen metabolized well? Your cortisol dysfunction, melatonin insufficiency, and oxidative stress, if you were to put those in sort of a hierarchy of your expectations of how tightly those would be related to breast cancer, what sort of comes at the top of the list for you in that?
Yeah, so I am almost directly flipping to where is the progesterone and what is the adrenal function.
Yeah.
Because that is kind of the tell for me of where are you in terms of your reserve, in terms of your plasticity, where are you? If I'm being honest, most women who have a breast cancer diagnosis and think that the DUTCH is somehow going to tell them something about their estrogen that is going to be enlightening, nearly, not 100%, but nearly all of my breast cancer patients, when they take the DUTCH, we can barely measure their estrogen. There's virtually none.
People on treatment that are on treatment?
Well, most people come to me after they've already been diagnosed, right? And as we said before in this podcast, breast cancer is not a disease of hormone excess. It's a disease of hormone deficiency. So they have minuscule levels. And these aren't people on aromatase inhibitors. These are just the population of postmenopausal women that get breast cancer. They have almost immeasurable levels of hormones because, as I hope we very clearly stated, hormones don't cause breast cancer. That's not the thing. It's not why you got breast cancer, right? And if anything, estrogen is an innocent bystander in this entire story. And while a tumor will alter the environment around it and upregulate what we call aromatase, which is the enzyme that converts testosterone to estrogen, so it will do its best to create an estrogen-rich environment. But estrogen is just the innocent bystander there. That's just the tumor's last ditch attempt to survive, right? It's just trying to create an environment that it can live in, because the whole reason that the tumor got there in the first place is cancer's a normal response to an abnormal environment. And there was some global environmental shift that allowed these cells to feel threatened enough to go into survival mode. That's all that's happening there. So when I get a DUTCH on a patient, although if I'm being honest, so many of them come to me with their DUTCH in hand saying, here, tell me why I got breast cancer, right? And the answer is not there, but do I see the signs of it? Yeah. And so when I see someone who has low melatonin, and I think the more dangerous profile for me are the ones that also have very low cortisol and cortisone levels, right? This is someone that is well beyond their ability to acclimate, right? They're tanked.
Right.
They're tanked. So these are the things that I'm looking for, and I'm looking for that oat at the end, right? I'm looking for signs of DNA damage, signs of increased lipid peroxidase. I'm looking for signs of imbalance in the system that I know, well, this isn't the thing, but this is someone who maybe we can help them. Maybe there are touch points there. But I'm looking for ways to help them improve. And I think that the DUTCH test is a really good indication of that. But I'm not necessarily looking for how you're breaking down your estrogen, because usually there's so little estrogen that we can't really make that assumption from the information. And also, I don't think that's anyone's primary problem.
Right. Yeah, and to kind of finish off the other part of that question, Jaclyn, in terms of what we see, I think you talked about inflammation, and when you've got long-term inflammation, that really lights up a lot of different areas on the DUTCH test as far as having high kynureninic acid. That tryptophan metabolism shifts when there's inflammation, and then you get high cortisol with acute inflammation, but with that long-term inflammation, the pattern that you described is much more oftenly seen in terms of having low cortisol. Oftentimes we'll see higher levels of cortisol metabolism, because that long-term inflammation can kick up your body's processing of cortisol. And then the other marker that plays into that a little bit indirectly is if we see high pyroglutamic acid, because if you've got a glutathione deficiency, then that's related, maybe not causative, but related in terms of just if you're not doing well on the glutathione side of things, then getting rid of those bad estrogen metabolites is going to be a little bit harder. So there are a number of those things that we're looking at, not as much on the cause side, but just tying that all together with inflammation and some of that metabolic picture that you're describing.
And just proof that someone's struggling, right? Like it's an indication that they've kind of exceeded their body's ability to deal with their environment, that they've used and overused their resources, and their body is just tired.
Right.
Well, we've talked about so much, but I have to wrap by sharing with you that I was thinking about you so much this last month, because on March 31st, the Journal of Clinical Oncology, or JCO, which is the American Society of Clinical Oncology's journal, published a commentary titled Menopausal Hormone Therapy After Breast Cancer, Personalization, Not Prohibition. So you can search this. It's partially open access, but what I want to read a quote from that, because I think it's like a pat on the back to all the work you've done, Dr. Simmons. It says, the contemporary management of cancer focuses on effectiveness of treatment while aiming to maintain quality of life. They go on to kind of talk about a little bit about that. And while there are therapies available like antidepressants, the use of vaginal hormones, which are, providing localized absorption to mitigate symptoms related to genitourinary syndrome of menopause, menopausal hormone therapy has been considered contraindicated. But for women in whom quality of life is sufficiently compromised because of menopausal side effects, such blanket prohibitions against menopausal hormone therapy deny breast cancer survivors a treatment option that's less costly than many alternatives and highly effective, with benefits beyond addressing menopausal symptoms. And, get this part, the totality of data not supporting its absolute contraindication after a breast cancer diagnosis. And I want to just pat you on the back, because I think this is a song you've been singing for a long time. And I think this is going to shake the industry to maybe start to look at some of those studies and realize, with the Women's Health Initiative, we have said that was a faulty conclusion. Let's move on. But I feel like breast cancer survivors were kind of the last remaining subset of women where we've said, absolutely not. Yeah. It's kind of like the last lingering piece that's holding on to WHI. Yeah. And so I'm so excited to hear this, let's look at the evidence approach. So what do you think about that?
Well, I'm not at all surprised, because this evidence was sure to come out. And even when you look at the book Estrogen Matters, which I think was first published in maybe 2018, where Dr. Avram Blooming looked at all of the studies in the breast cancer population. And of the 20 studies done between 1999 and 2015 or something like that, there was only one study that had negative outcomes for women who had breast cancer and took hormone replacement afterwards, and that was the HABITS trial. And the HABITS trial used a very high amount of one of the progestogens, like one of the synthetic progestins, and even in that trial, only the women that also took tamoxifen did they show an increased risk of recurrence. And everyone else and the other 20 trials showed either no increased risk of recurrence in women who had breast cancer and took hormone replacement afterwards, or a decreased risk of recurrence. And if you think about it, if you are taking a woman who had breast cancer, and instead of depriving her of hormones, you are providing her with hormones, you can protect her heart, protect her blood vessels, protect her bones, protect her brain, protect her mood, protect her sleep, protect her bladder, protect her vagina, and when you protect her joints, and when you do all of this and you diminish suffering, you're going to have better health, which is going to result in less recurrences, longer longevity, and better quality of life. So it's just logical that hormones are only protective. However, does that mean that we should be putting everyone on hormones? No, absolutely not. This needs to be an individual conversation without question, and it needs to be done thoughtfully, safely, and individually, right? And we are not giving hormones to everyone, and we're certainly not giving the same hormones to everyone, and we're not giving the same dose to everyone. Because, again, as my kids say, Mom, that's not how it works. Right? And we need to approach everyone as an individual and meet them where they are. And if you are in the throes of breast cancer treatment, now is not the time. But there is a huge distinction between have breast cancer and had breast cancer. And if you had breast cancer, what we were telling people is you should be grateful to be alive. But it is very hard to feel grateful when you can't think and you can't sleep and you're nervous and you're anxious and your bones ache and your joints ache and you've gained weight and you don't recognize your body anymore and you have urinary tract infections, you have yeast infections, you have no libido, sex is unwanted, sex is painful, your relationship is either strained or absent. It is very hard to feel grateful, and yet this is how we are leaving most women after breast cancer treatment, and it's the wrong thing to do. And it is high time, it is past time for us to start to acknowledge these women and say, I hear you, and we can offer you the same thing that we are offering to everyone else and not put you in danger and, in fact, enrich your life. And this is what we need to be doing. And now we have the evidence. We've always had it, but no one was saying it loudly enough. Now we have the evidence to stand on to say, this is what we should be doing. We should be meeting everyone where they are and say, what do you need right now?
I mean, and the other piece of this, I love what you're saying. And the other piece that's really jumping out at me is that, like, women are not just breasts, right? That's what I'm hearing you say. After breast cancer, even still, women are not just breasts. They are a whole human being that deserves to feel great.
Yes.
And, you know, we can talk about the medical risk, but I think we need to think about women, as whole people, even after breast cancer. So thank you so much.
Absolutely.
One final question for you today is that we've been hearing so much about the use of testosterone in women. And I feel like we can't leave this podcast today without talking at least a little bit about testosterone in breast cancer. A couple things, like we're seeing a kind of a debate in the scientific community, in the clinical community, around testosterone's use in women. You have some prolific researchers like Professor Susan Davis, who continues to support, like, given all the body of research she's been a part of, libido is really the most statistically relevant application of testosterone in women. You have other researchers who are looking at it from a broader point of view, because women are reporting feeling better on testosterone. And actually, April 7th of this year in Menopause, Sarah Glynn published a small study in breast cancer survivors. It's called Use of Transdermal Testosterone to Treat Menopausal Symptoms in Women with a History of Breast Cancer, a small retrospective open label study. And it really it was at 47 women, UK. They used the menopause symptom questionnaire to, like, ask about how women felt. They evaluated fatigue, cognitive symptoms, and reduced libido, night sweats, anxiety and panic, depression, anhedonia, palpitations, and a lot of other symptoms. What they found was that there were a lot of improvements in many other symptoms beyond libido. And I think fatigue, libido, and cognitive symptoms were the ones that were most improved. But libido was by far the best. However, I think the thought is, like, could testosterone therapy be a safe addition for women with breast cancer? Do we know that yet? And what are your thoughts or your experience maybe working with testosterone in women in this group?
Well, I think that Rebecca Glazer has published her 20-year data on the topic. And from my perspective, this is an area where the science is settled. And she has 20 years of the use of testosterone with or without an aromatase inhibitor, because I think there was a time when she did believe that estrogen was bad, probably as a result of working in a system that accepted the findings of the Women's Health Initiative. So for for at least a portion of her population, and she worked with women both with and without a diagnosis of breast cancer. So she either gave testosterone alone in the form of pellets, or she gave testosterone and an aromatase inhibitor in the form of pellets. And her data is staggering. She has an 87% reduction in breast cancer as compared to the general population. Now, if this doesn't scream that testosterone is protective against breast cancer, I don't know what does. Mm-hmm. And I am universally using testosterone in my patient population, both my pre-vivors and my survivors, and even my women with active disease, with metastatic disease. And it's because one of the properties of testosterone in the breast is that it is anti-proliferative. And so I very confidently use it. And yes, I'm using it for libido, but I'm also using it for cognition, for metabolic health, for confidence, for people to continue to feel like themselves and have the desire to really live this life, because that is highly predictive on how you do, on how long you live. How long you live, by and large, is how long you want to live. And testosterone makes you want to live.
Mm-hmm. Yeah, I think there are a lot of people in our industry and particularly individual women that are indebted to Dr. Glaser for that work that gives people the confidence to be able to have that in their toolbox specifically for those women.
Yeah, I was hoping you'd bring that up. Well, what a wonderful note to end on today. Dr. Simmons, thank you so much for joining Mark and I for the pod, and Mark for providing all the additional insights on the Dutch test as well, because I think this is an area where there's so much opportunity for us to really look at this from a more comprehensive point of view, for both in the overall clinical picture and when you're looking at a Dutch report. Thank you both for joining me.
Thank you.
Thank you for having me. It was wonderful.
Dr. Simmons, if people want to connect with you, what is the best way for them to do that?
Yeah, so if you're looking for breast cancer screening, and when we screen for breast cancer, we screen for your overall health. So that's happening at Perfection Imaging, and Perfection is spelled with a QT in the middle. If you're on a breast cancer journey, go to JennSimmonsMD.com, and my Jen has 2 N's. I have a podcast myself. It's called Keeping Abreast with Dr. Jenn, and there we talk about all things as it relates to women's health. You can find me on all the social media channels. I'm at Dr. Jenn Simmons, and again, my Jen has 2 N's. And I have a best-selling book called The Smart Woman's Guide to Breast Cancer, which is not only what everyone who has a breast cancer diagnosis needs, but it's also how to prevent a breast cancer diagnosis, because at the end of the day, breast health is health, and the same things that you're going to do to have healthy breasts is going to give you a healthy brain and healthy bones and healthy joints and healthy heart and healthy gut, healthy mood, healthy libido, healthy everything.
Thank you so much. And thank you all of you for listening and joining us today for this really important conversation. If you like what you heard and you want to hear more about women's health and hormones, definitely follow Dr. Simmons' podcast, and you can also listen to us at The Dutch Test. We release a new episode every Tuesday, so be sure to hit subscribe wherever you're listening today so you can catch every podcast episode, and you can follow us on socials at Dutch Test. Thanks so much. See you next week.
Thanks for joining us on the Dutch Podcast. Join us every Tuesday for new conversations with leading functional health experts. If you like what you've heard, be sure to like, follow, and subscribe wherever you get your podcasts.